Hi, I'm Dr. Akhtar Amin and today our topic is fungal keratitis. Fungi are a group of microorganisms. They have rigid walls, they have distinct nucleus, they have multiple chromosomes and they contain both DNA and RNA. Fungal keratitis is rare in temperate countries, but it is a major cause of visual loss in tropical and developing countries. Though often evolving insidiously, the fungal keratitis can elicit a severe inflammatory response, and corneal perforation is common. The outlook for vision is frequently poor. There are two main types of fungi which cause keratitis: yeast and filamentous fungi. The common yeast are genus Candida. They are ovoid unicellular organisms. They reproduce by budding. They are responsible for most cases of fungal keratitis in temperate climates. While the filamentous fungi, the most common are Fusarium and Aspergillus. They are responsible. Uh, they produce tubular projections called hypae, and they are the most common pathogens in tropical climates. And they are not uncommon in cooler regions. The keratitis frequently follows an aggressive course. The predisposing factors include chronic ocular surface disease, long-term use of topical steroids, often in conjunction with prior corneal transplantation, contact lens wear, systemic immunosuppression and diabetes, while filamentary keratitis may be associated with trauma, often relatively minor, involving plant matter and gardening and agriculture tools. Now we will discuss Candida and filamentous keratitis. The diagnosis is frequently delayed unless there is a high index of suspicion, and often bacterial infection will initially have been presumed. The clinical signs are not a definitive means of distinguishing bacterial and fungal corneal infection. Signs such as satellite infiltrates, which we will discuss, they can be caused by other microorganisms. The symptoms are gradual onset of pain, grittiness, photophobia, blurred vision, watery mucopurulent discharge. Now first we will discuss Candida keratitis. There will be yellow-white, densely suppurative infiltrate in Candida keratitis, while in filamentous keratitis there is grey, yellow-white stromal infiltrate and indistinct fluffy margins. There is progressive infiltration, satellite lesions. Satellite lesions are smaller lesions near the principal lesions. There is feathery branch-like extensions on a ring-shaped infiltrate. Feathery branch-like extensions may develop. There is rapid progression with necrosis and thinning can occur. Penetration of intact descent membrane may occur and lead to endophthalmitis without evident perforation. There is an epithelial defect, and the epithelial defect is sometimes small when present. Other features include anterior uveitis, hypopyon, endothelial plaque, raised intraocular pressure, scleritis, sterile or infective endophthalmitis. The differential diagnosis includes bacterial, herpetic, acanthamoebal keratitis. Bacterial infection may sometimes present in a subacute fashion, particularly when atypical organisms are responsible. It is important to be aware of co-infection, including an additional fungal species. Investigations. Samples for laboratory investigation should be acquired before commencing antifungal therapy. Staining. Potassium hydroxide preparation with direct microscopic evaluation is a rapid diagnostic tool that can be highly sensitive. Gram and Janssen staining, they are both about 50% sensitive. Other stains include periodic acid SCIF, chalcofluor white, and methenamine silver. Culture. Corneal scraps should be plated on seborrheic dextrose agar. Although most fungi will also grow on blood agar or in enrichment media, it is important to obtain an effective scrape from the ulcer base. Sensitivity testing for antifungal agents can be performed in reference laboratories, but the relevance of these results to clinical effectiveness is uncertain. If applicable, contact lens in cases should be sent for culture. Polymerase chain reaction (PCR) analysis of specimens is rapid and highly sensitive up to 90% and may be the current investigation of choice. Calcium containing swabs can inhibit polymerase activity and local collection protocols should be ascertained prior to specimen collection. The corneal biopsy. It is indicated in suspected fungal keratitis in the absence of clinical improvement after 3 to 4 days and if there is no growth develops from scraping after a week, and a 2 to 3 mm block should be taken. Similar to scleral block, excision during trabeculectomy. Filamentous fungi tend to proliferate just anterior to descendant membrane, so deep stromal specimen may be required. The excised block is sent for culture and histopathological analysis. Anterior chamber tape has been advocated in resistant cases with endothelial exudates because organism may penetrate the endothelium. Confocal microscopy frequently permits identification of organisms in vivo but is not widely available outside tertiary centers. Treatment. Improvement may be slow in comparison to bacterial infection. General measures are as for bacterial keratitis, although hospital admission is usually required. And the general measures are discontinuation of contact lens wear, clear plastic eye shield, and causative organisms cannot be defined reliably from the morphological appearance of the ulcer. So empirical broad spectrum treatment is usually initiated. Removal of epithelium over the lesion may enhance penetration of antifungal agents. It may be helpful to regularly remove mucus and necrotic tissue with a spatula. Topical antifungals should initially be given hourly for 48 hours and then reduced to as sign permits. The candida infection is treated with amphotericin B 0.15% or econazole 1%. The alternative include natamycin 5%, fluconazole 2%, clotrimazole 1%, and voriconazole 1% or 2%. Now the filamentous infection treated with natamycin 5%, econazole 1%. Alternatives are amphotericin 0.15%, miconazole 1%, voriconazole 1 or 2%, and several others are also available. A broad spectrum antibiotic might also be considered to address prevent bacterial co-infection. Cycloplegia is for bacterial keratitis, subconscious fluconazole may be used in severe cases. Systemic antifungals given in severe cases when lesions are near the limbus and for suspected endophthalmitis. Options include voriconazole 400 mg twice daily for 1 day, then 200 mg twice daily. Itraconazole 200 mg once daily, reduced to 100 mg once daily. Fluconazole 200 mg twice daily. Tetracycline, for example doxycycline 100 mg twice daily, may be given for its anticollagenase effect when there is significant thinning. Perforation, actual or impending, managed as for bacterial keratitis. Superficial keratectomy, effective to debulk lesion. Therapeutic keratoplasty, penetrating deep interior lamellar when medical therapy is ineffective or following perforation. Anterior chamber washout with intracameral antifungal may be considered for unresponsive cases in which there is a stable corneal infiltrate but enlarging endothelial exudates. Thank you so much.